practice, and we'll discuss about this one. A classic meconium, asphyxia, meconium distress, issues with the perfusion, issues with the blood pressure, issues with the ventilation, high frequency, 100% oxygen, hypotension. And just now I showed you the echo. That's the echo of this baby. Apical 4 chamber, severe TR jet, pulmonary pressure measured 67 with a bidirectional PDA in this baby. And this is the bidirectional PDA in this baby. At the same time, the baby has the bidirectional PFO. This is an example of bidirectional PFO. That's a subcostal long axis at atrial level, RA, LA, and this is what we say. This is the bidirectional at the atrial level. Shunts are bidirectional. Pulmonary pressures are high, but the good thing is that the ventricular functions are normal in this baby. That's the functional echo which we have done, and you guys have observed from that one. So this is what you guys have seen so many times in the pictures, that this baby has a TRJ, this baby has RV dilatation, this baby has a bidirectional PFO, bidirectional PDA, classic PPHN. Classic PPHN, what we are dealing, let's see what happens about the treatment. The most important part, what are our goals? Our goals are avoiding or treating the oxygen or treating the oxygen therapy, avoiding hypoxia, maintaining the perfusion, and decreasing the pulmonary resistance. That's the goal we have to achieve in cases of naturally the pulmonary hypertension, what we are doing. So when we see about, this is the important slide about the summary slide, but probably the first slide, that initial stabilization is the most important. In India, a lot of these babies are outborn, hence they are hypothermic, hypoglycemic, hypocalcemic, hypomagnesic, probably polycythemic. These are the things which give more trouble. These are the things which we are in problematic rather than these things. Hence, we have to concentrate stabilization. We have to concentrate on recruitment of the lung. We have to concentrate on vasopressin and vasodilators. These are the 4 components we discuss about the babies when we think about such baby what we just saw. So the basic management comes as the oxygen therapy, recruitment of the lung with ventilation, with opening of the lungs by the surfactant therapy, and side by side vasopressor therapy to improve the blood pressures. So just now I mentioned, most important thing is please maintain the normal. What are normal? That means temperature, calcium, magnesium, sugar, electrolytes, all those things, please keep in the normal range. Everyone has a role, and that role you have to maintain in cases of pulmonary hypertension. The most important factor, most important drug which is still there is oxygen. But you don't want too less and you don't want too much. In Marathi we call ऊस गोड झाला म्हणून मुळासकट खाऊ नका. Means don't give too much and don't give too less. You have to maintain that in the range, because oxygen is a powerful vasodilator. So when we're talking about oxygen is a powerful vasodilator, we need to work as avoiding that oxygen as very high, because the high oxygen has a pre-oxygen radicals. So when we talk about this high oxygen, we are creating these pre-oxygen radicals, and these pre-oxygen radicals naturally impairs the endothelial nitric oxide synthesis. And ultimately, when you say that nitric oxide synthesis is impaired by this endothelial nitric oxide synthetase enzyme, we are in big trouble. So naturally, we have this dysfunction, or ultimately leads to vasoconstriction. So one side you want to work as a vasodilator, but because there is hyperoxia, you end up with vasoconstriction. Hence, old technique of giving 100% oxygen, old technique of keeping saturation 97, 98 gone. We are all happy between 90 to 95. We all are happy with the saturation of 50 to 80. That is the first golden rule in case of pulmonary hypertension. So we talked about oxygen. Think about normal blood to carry that oxygen. That means you need to maintain that hematocrit. You need to maintain that hematocrit and hemoglobin in the first week, preferably between 12 to 15, 12 to 14. That's what you require. You might require blood transfusion in some babies. Maintain that hemoglobin. You don't want polycythemia. I just mentioned one of the cause of pulmonary hypertension is polycythemia. You don't want polycythemia, you don't want anemia. Both are important. So what I told you, oxygen is a potent vasodilator, but hypoxia is detrimental as for the brain, as you all know. Hyperoxia is also too much detrimental because of the formation of free oxygen radicals. Ultimately, vasoconstriction, impairment of the nitric oxide. These are the issues. Hence, you want saturation 90 to 95. Hence, you want your PO2 between 50 to 80. Preterm, I keep 50 to 70. Term, I keep preferably 60 to 80. These are the range, nothing in the books, but these are the range of the practical things what we do manage day to day. That's about initial stabilization of oxygen. Very important. Oxygen you might have to give through the CPAP, through the gentle ventilation, or through high frequency. That is the need of the baby, what you have to decide. The second thing what we are talking here is the most important thing is lung recruitment. Any disease in the neonatology, your lung has to be recruited proper. If your lungs are not recruited proper, medications will not work. Hence, the golden rule in neonatology is a proper recruitment. And that optimal recruitment is achieve your FRC. You don't want underinflation, you don't want hyperinflation. You are happy with the posterior ribs of 8 to 9. That is very important. Because underinflation also has a problem in the form of worsening hypoxia and hypercardia. Overinflation will decrease your venous return, leads to systemic hypotension. You don't want both. And what you want ventilation. You want gentle ventilation. You don't want to create pressure trauma, that is barrow trauma, volume trauma, attenuative trauma, flow trauma. All the traumas you don't want. Basic neonatology. You all know that, but still I'm repeating. You might have to use high frequency, and please use early surfactant. Especially in cases of meconium, in cases of pneumonia, use early surfactant. Because if you don't open the lungs, your nitric will not work. If you don't open the lungs, your oxygen will not reach there. Hence, recruitment or opening of the lungs is the most important thing. And that is where a lot of time we struggle of management of pulmonary hypertension. My golden rule here is that use that surfactant as a water and open that alveoli, open the recruitment. Because if you do that surfactant, you will be able to open the lungs and improve the vacuum mismatch, improve your vasodilatory effect. What do we want? We want ventilation here. Here you could see the blood flow. Here you could see the PO2 and the PCO2. You don't want hyperoxia, you don't want hypocapnia, and you don't want high ventilation, because both of them will affect your pulmonary blood flow as well as cerebral blood flow. What you want your PO2 between, just I mentioned, you want your PO2, what is preferably is in cases between, I told you that 50 to maximum 70, 80, your CO2 has permissive hypercapnia, which is between 40 to 55. That is acceptable range in these babies. That is what we are discussing. Otherwise, it will hamper your pulmonary blood flow, it will hamper your systemic blood flow, it will hamper your cerebral blood flow, which you don't want. So what is your target? Please, old days are gone. You don't want alkalosis. This slide probably just for teaching purposes I have written, but I don't accept any pH nowadays above 7.3. I'm happy between 7.25 to 7.3. That's my acceptable range. PO2 between 50 to 80, CO2 between 40 to 55. Rates, naturally, you might have to use the assist control here. Minimal chest rise, proper sedation, proper analgesia, avoid paralysis, avoid hyperventilation. So what you have to avoid? Too much handling, avoid too much noise, avoid too much suction. Finish the thing in the golden hour. The first golden hour is important. If you want, put a right radial arterial line. Always put right radial arterial line. That is a preductor. You have to put UVC or line because you require multiple drugs. Intubation. And once you finish in 1 hour, please don't touch baby too much. The biggest thing happens in medical school. Resident has taken round, senior resident takes the round, lecturer takes the round, professor takes the round, teach too many rounds. One person has done echo, second person has done echo. Oh, I got a good finding. Third person does the echo. All this handling deteriorates the baby. One person, one echo is enough. He can save the images, he can save the videos, and other can see that. Don't do too much handling. Otherwise, baby deteriorates, and to recovery of the baby takes more time. It is too much time. So that should not happen in these cases. That is very important. And that's what I've written, that what we want, target ABG. We also want a normal blood pressure, preferably between 40 to 50. You also don't want too much. You also don't want too less. Normal saturation 90 to 95. If you are transcutaneous, very few units in India has a transcutaneous PO2, PCO2. If you have that facility, then use the transcutaneous PO2, PCO2 again in the normal range. The most important thing, a lot of babies of this meconium, especially in asphyxia, will require high frequency ventilation. And in my own unit, we use early high frequency ventilation. I don't wait the EIP of 25. My cutoff is 22, 23 because I don't want to damage lung. Tidal volume probably 5.5 to 6. If I have to more than 60, and your PO2 is still high, PO2 is still low, PCO2 is still high. Especially in meconium, I use early high frequency. I use early surfactant. Hence, the role of nitric has gone down. Nitric is white elephant. Lot of referral babies, they only require nitric. Inborn babies, I don't require nitric. So use of the high frequency along with nitric, very good results. But I would say that high frequency plus surfactant, that's the best thing. That gives you a quick recovery. And if you are using the high frequency, then nitric, okay, that's the one what you use. And that's what I told you, that in cases of meconium, pneumonia, early onset sepsis, I use liberal surfactant. And they have good results. If you see our own paper, that surfactant therapy for congenital pneumonia, which was quoted in the IDS guidelines also. So we use surfactant quite frequently for congenital pneumonia. Similarly for meconiums, we use early, and we use second dose early within 6 hours also. Surfactant improves your EQ mismatch. It decreases in shunting. It decreases need of nitric, naturally decreases need of ECMO, which I don't have, but that's what is better outcome. Our indications are that once your OI starts crossing 5, 6, I start giving, preferably at 5, I say, okay, shoot. If I have to, in term babies 40%, in the late preterm about 30%, I use surfactant. So early surfactant therapy, what we use in these babies, that is what we try. Dose is same, monitoring is same, as you know, a lot of you are doing that, but still I'm repeating these ones, which is very important. If you see the lungs, which is the lung disease, naturally there are collapse, there is overdistension, and there is hypoxic respiratory failure, leads to increased vascular resistance. If you use the nitric in this lung without surfactant, some lungs are still collapsed. Still there is increased pulmonary vascular resistance. But if you use the nitric after surfactant therapy, so this is the surfactant therapy, then you use the ventilation plus nitric, you have a fantastic opening of the all lungs, you have fantastic improvement of the oxygenation, why? And you have a decreased PVR in these babies. That is what we are talking. Hence, this is enough literature on that. Please use surfactant early in the secondary pulmonary hypertension, especially meconium, pneumonias and sepsis, where you should use this one. That is very important. Once the baby is stable, once you have acceptable gas, then start weaning. Now I have not touched the nitric, I'll come to the nitric later on, because that's where people all will think. Once my pressures are less than, once my oxygen is less than 50%, then I touch the pressure or map. Till that time I don't touch. And the pressure is extremely slow weaning, 1. If it is a high frequency, map by 1. If it is a PIP, in conventional, 1 or 2 max, but I don't touch too much. Bring down the pressures to 18 to 20. Bring down the map in term babies by 8 to 9, in the preterm up to 6, and then think to shifting to conventional, or then think to extubation. Extremely slow weaning of the vasodilators. Oxygen, which is the one which you win the first, not more than 2 to 3%. Suppose babies are 100%, come to 98%, 96%, 94% every 30 minutes once your saturation is above 95. Pressures, I told you 1 to 2, drugs by 20%. Suppose you are on 10 mics, then come to 8 mics, 6 mics, that's where we win about the drugs. So winning is art. If you learn the slow winning, but also you don't want hyperventilation, also you don't want too much also. So sometimes you require more gases, or you can see proper tidal volume, you can see proper oxygenation, that will be beneficial. So this is what I think basic you learn, the basic management, you learn about saturation monitoring, you learn about surfactant, you learn about the maintaining of the conventional ventilation, high frequency ventilation, and monitoring of the vital signs. That is what is major things which is important, because initial management is the one, if you manage that initially well, you might not require a lot of time high frequency, you might not require a lot of time nitric oxide. A lot of people say I don't have nitric oxide. Okay, doesn't matter. Stabilize the baby, very important in 1 hour. So remember this 1 hour period, which is important. What about vasodilators? Now we have 2 vasodilators which are available importantly, nitric and sildenafil. Some units have nitric, most of the teaching units have nitric now, but still some units struggle with nitric. We'll discuss that for sildenafil. So you want to improve your systemic pressure and you want to decrease your pulmonary pressure. And naturally, we want to decrease your pulmonary pressure. For that, you require early use of vasodilators. So in this case, initial stabilization and use of vasodilators, normal ventricular function, blood pressure is also okay. So I think early use of these vasodilators, which are acting on cyclic GMP, as nitric oxide, as you all know, improving cyclic GMP leads to vasodilatation. I'll come to that sildenafil later on, but these are the ones which you need to think about early use. As you know, the nitric oxide has action on cyclic GMP. You know the nitric oxide is a selective pulmonary vasodilator. That's the beauty of nitric oxide, because it is inactivated by the hemoglobin in the circulation. Hence, it has no systemic side effect. That's the beauty of the nitric oxide. It also has a microselective action, and that's why it improves your ventilation perfusion. And that is what you require surfactant to open up the lungs to improve that things. Hence, combination of high frequency and nitric, just I told you, combination of high frequency nitric oxide has a better results. If you see this Gonzalo trial, where plain nitric versus nitric plus surfactant plus high frequency, they have a better outcome, decreased death, decreased need of ECMO. Hence, when you use surfactant early, which has a better result. When you use the combination of high frequency surfactant nitric, better result. What I'm trying to tell you. I think a lot of you know this one, but what we do as why I don't wait till 20 nowadays. I start at 15. That might be too much, but for early thing, we do early. That's what I told you, surfactant also, we do early. So early, hammer fast. Don't wait till 20. Why? That's what I feel that if we target at 15, naturally, we start with 20 dose, agree on that. And the response you see in 10 to 20 minutes, response in the form of improvement in saturation, response in the improvement in PO2, and response in the form of ratio of PO2 FiO2. But the best response, once you start, immediately after 5 minutes, resident will come and she'll say, sir, happy. Saturation is improving. Immediately the whole team is happy, everything is happy. That's the beauty of the nitric oxide, and that's the reason why we say it's a magic drug. Winning, I think, again, in individual protocol, my unit protocol is that I wait till 50% oxygen, that is 0.5. Some units say 0.6, but I wait till 50%, and then PO2 is more than 60, less than 80. That's what I maintain, 60 to 80 in term babies. Saturation between 90 to 95. Once the FiO2 is 50%, I start winning. Naturally, what we do is same protocol, 5 parts per minute, every 4 hours, little 5 parts. And then slowly 1 by 1. What about the nitric in the Cochrane data? Yes, we all know nitric is the best drug for hypoxic respiratory failure in a term baby, early term babies, preferably about 35 weeks. What we are talking, the preterms we don't have enough literature. We know about decreased need for ECMO, improved OI, improved PO2, all the Cochrane data, as you know, but still repetition. So nitric is a safe, effective in term and near term babies. In the preterm babies, it is still, we are not talking as the first line, we are talking as reserve medication for the purpose of when you don't have options, then you might use, or in cases of severe BPD, pulmonary hypertension, that time probably some people are trying, but in preterm at present moment, there are no for nitric, but a lot of unit must have used as a case reports that as you know. The problems of the nitric is one is availability and cost. In medical school also, suppose a medical school like us, where the day of cost goes 25,000, so it's big problem. 30 to 40% non-responder. It's not like all the babies will respond. It's not 100% thing. Maintenance is there, cost is there. That's what I said, it's white elephant. My statement for nitric is white elephant. So please work on that early management. Please work on stabilization. You might not feel proper. So that's what is the nitric about starting and weaning, those simple things. You can, all those things are in the books. But still, as you know, nitric has for hypoxic respiratory failure with a documented. For nitric, you should have echo must. Structural normal heart, echo with severe pulmonary hypertension. That is mandatory. OI, I told you I don't wait now 20 or 25. I start with 15. That's my cutoff. Dosage 20, as you know. Monitoring, you require all the basic monitoring, and then you start weaning. Nowadays, I don't do the methemoglobin because most of the nitric we are using is 3 to 4 days. Once the baby is not responding to that, please stop early. Don't wait 5 days and 7 days. Most of the nitric you are happy between 3 to 5 days, maximum 3 to 5 days is enough. Don't play with that. It's very costly. So that's what we don't do methemoglobin. And we are happy with the basic management of that 3 to 5, what we are talking here. We have to be careful about optimization. You don't want over ventilation. You don't want under ventilation. For nitric, your recruitment has to be good. That's what I just mentioned. Proper ventilation, proper surfactant, good recruitment, then and then you should have a good thing. Nitric is contraindicated when you have diaphragmatic hernia with your LV dysfunction or duct dependent circulation. That time you can't use the nitric. That is not there, or the preterm less than 34 liters. The next question comes in the mind. Is sildenafil is the new nitric? That was the 20 years before we were talking, or 15 years before we were talking in India. What is this sildenafil? As you all know, the sildenafil is a potent vasodilator. This is a phosphodiesterase 5 inhibitor. Again action on the cyclic GMP, and naturally we have vasodilatation through this effect. And then we say that the dosage of oral is 1 to 2 milligram. IV dosage is 0.14, 3 hours followed by 0.07 maintenance. Special role for sildenafil is in the preterm BPD pulmonary hypertension. Naturally, sildenafil is not without side effects. You have to be careful about the bleedings, hypotension, pulmonary hemorrhage. These are the major complications. Because sildenafil is also systemic vasodilator. It is not only a pulmonary vasodilator. So that's why we have to be very careful about sildenafil. As you all know, Cochrane says, as you know, that the sildenafil is for PPHN, especially in resource limited settings where nitric is not available. Reduction in mortality almost by 2%. That's RR is very good. So you have to be well versed with the use of sildenafil. That's the Cochrane data, as you all know. You all see that there is a improvement in OI, and that's some important thing. What is important is that most important thing is that your blood pressure should be normal, or you use the vasopressor to improve that blood pressure and then think about using sildenafil. Otherwise, a lot of time you will struggle using sildenafil and hypotension. Be careful. sudden deterioration, very severe hypotension, you might have to stop that sildenafil because severe systemic hypotension is a major side effect and common side effect about sildenafil. We know that there is oral sildenafil and IV sildenafil, but there is no trial about oral versus IV. So one of our DM candidate, Dr. Chinmay, has done this comparison of oral versus IV, and that what he has he has compared the mortality and he has compared the complications. Naturally, most of the parameters were comparable, but the babies with the oral sildenafil were more sick babies, and the babies with the oral sildenafil has a less complication. So sick babies with less complication by oral sildenafil, what he has documented, and that paper now is in the pipeline for publication. So that is what we need in India, that yes, oral is effective and we need to document that, and that is what he has documented, that the oral sildenafil has similar response to the IV sildenafil with a lower complication rates, hence we can use oral sildenafil in Indian scenarios. So what is the first thing I want to tell you? The first thing I want to tell you in the approach in India, the most important approach is initial stabilization. That's a backbone. This backbone is for oxygen therapy or recruitment with ventilation and high frequency ventilation. But early surfactant therapy is very important. Early nitric oxide, if your nitric is available, I told you I don't wait for 20, I start with 15, that is my first line. But if I don't have, then we use oral or IV. Naturally, that's the second line written, but some units has a first line. We need to stabilize your blood pressure by fluids, vasopressin, steroids. We'll come to that point, but that is the most important aspect. That's the first case what we discussed with normal ventricular function. So we have discussed that there is a pulmonary hypertension, but ventricles are okay. So far, so that's what we are talking here. Let's discuss the case 2. This is the late preterm, gift of India, outborn baby, severe late onset sepsis, suspected late onset sepsis, probably Klebsiella or Acinetobacter, hypotension, ventilation. Along with that, functions of pulmonary hypertension, TR jet, MR jet, bidirectional PDA. This baby has pulmonary pressures documented as G2 by the TR jet. TPV or VET, just was crescent shaped, and this baby has LV dysfunction. This EA ratio is less than 1. This RV ratio is less than 1. So this baby has ventricular dysfunction. That's a marker of severe dysfunction as EA ratio. By tissue Doppler also you can document the methods of the ventricular functions are different. So these are the methods of ventricular dysfunction. Doppler is another method of ventricular dysfunction. What we have documented in this case by echo, this baby has late onset sepsis with vasodilator shock with a dysfunction. So when we are talking about the dysfunction, we have another vasodilator. We have another vasodilator which acts on the phosphodiesterase 3, and that is action as a relaxation of myocardium. That means whenever there is a RV dysfunction or LV dysfunction, there is a relaxation, there is a inotropism, lusotropism effect. That's a combined dual effect, and hence we call inodilator, and that's the beauty of milrinone. But the problem with milrinone is, again, it has a systemic vasodilator also. So one side we are talking milrinone as improvement in RV function, improvement in LV function, improvement in a pulmonary vasodilatation, but there is issue of systemic vasodilatation also. So be careful. Like sildenafil, it has a systemic vasodilatation. So milrinone with a systemic vasodilatation, systemic hypotension. So just now I mentioned milrinone as a inodilator. So we are talking as a milrinone inodilator. Various studies various studies about the milrinone. There are case series which all documented decreased OI. One of our DM resident, Dr. Rima, has documented use of the milrinone in late onset sepsis for the purpose of ventricular dysfunction and improvement in the OI and improvement of mortality when you use milrinone. Again, that one paper is in pipeline from her side as improvement of the ventricular functions after use of milrinone. So milrinone in the pulmonary hypertension, that's what we say that this was the Cochrane. Is that time we have less studies, but that is lot of units are using milrinone, especially in term babies. But we need more data about preterm also for milrinone. People are now thinking about use of the combination of milrinone and nitric oxide. That means synergistic effect of cyclic GMP and cyclic AMP. So when you think about use of nitric plus milrinone or sildenafil plus milrinone, we don't have Indian data on this one, sildenafil plus milrinone. So suppose some students are listening, think about this one thesis about use of sildenafil plus milrinone. That could be better. Because when you are thinking about this pulmonary hypertension, you are thinking about ventricular dysfunction and you are thinking about increase after load. This increase after load, you are thinking use of the nitric oxide. And for this ventricular dysfunction, think about use of milrinone. So the severe pulmonary hypertension, this synergistic effect of inhaled nitric oxide plus milrinone sounds to be good because you are thinking action at two levels. Action at afterload, that is what pulmonary arterial hypertension, and action of the ventricular level as inodilator effect, or what I talk inotropism or lysotropism action, which is a cardiac relaxation action, which is by milrinone, which is useful. So milrinone is used in cases of PPHN associated with ventricular dysfunction, along with nitric oxide when there is inadequate oxygenation, less response to nitric. But again, you should control first dysfunction also, then nitric will work. So that is what is the role of this one. Dosage, I think a lot of you know about 50 to 75. Maintenance 0.3 to 1. Hypotension is another problem of the milrinone. So monitor that. We require fluids, we require vasopressor in this combination that is required. So what this case taught you? This case taught me that initial stabilization and optimization of the blood pressure. But in cases of myocardial dysfunction, you can use milrinone. That's what approach by functional echo you could able to document in these babies. That is about the role of milrinone. What about the vasopressors? That's another separate question. Vasopressors or inotropes in the PPHN. You have dopamine, you have dobutamine, you have epinephrine, norepinephrine, vasopressin, all those things. As you all know, you deal with the right ventricular dysfunction, you deal with the left ventricular dysfunction, and you deal with the pulmonary vasculature high. In short, you know that dopamine has action on mainly alpha receptor and some action on beta receptor also. Naturally, after the 10 mics, you have more action on alpha receptor. So the dopamine has, yes, very good vasopressor action. But unfortunately, dopamine also has a pulmonary vascular action. That means dopamine worsens your pulmonary vascular resistance. It is a vasoconstrictor effect. So it's a systemic vasoconstrictor as well as pulmonary vasoconstrictor. So in case of pulmonary hypertension, it will worsen. So I have stopped using dopamine last 10 years in my unit for sepsis cases or meconium cases where you have hypotension, where you have pulmonary hypertension. Pulmonary hypertension plus hypotension, you are in big trouble for use of dopamine because dopamine will worsen your pulmonary vascular resistance. What about norepinephrine? Fantastic drug which acts on alpha receptor. Along with that alpha receptor action, dopamine decreases your pulmonary vascular resistance. Very important statement I'm making. Sorry, not dopamine, norepinephrine. Norepinephrine decreases your pulmonary vascular resistance. One side it increases your systemic vascular resistance, and another side there is a pulmonary vasodilator. That's the beauty of norepinephrine. Hence, we are using norepinephrine as our drug in cases of late onset sepsis as a vasodilatory shock, which is always associated with pulmonary hypertension. Hence, we are using this norepinephrine unit. One of the resident again, DM resident has compared norepinephrine versus epinephrine, and norepinephrine sound to be equally effective. Hence, we're using norepinephrine. Again, that RCT is in the pipeline for publication. Comparison of norepinephrine versus epinephrine. What about the epinephrine? Yes, epinephrine has a very good effect on the vasopressor, that is alpha receptor action. It also has action on the heart, which improves, but naturally, you have to be very careful about, again, small action of epinephrine, about vasopressor action, about the pulmonary vasculature. So that is about epinephrine. What about vasopressin? Again, vasopressin has a similar effect like norepinephrine. Vasopressin has an effect like increase in systemic vascular resistance and decrease in pulmonary vascular resistance. So it is reserved for refractory pulmonary hypertension. We do use vasopressin rarely. If my noradrenaline fails, so then I add as a vasopressin in the unit as that one. Dopamine, mainly in cases of ventricular dysfunction. The dosage, as you know, but dopamine also you have to be careful about hypertension. Milrinone we discuss in detail as inodilator. That's what we use as a dopamine. Hydrocortisone, yes, especially in cases of sepsis-related pulmonary hypertension, I use the hydrocortisone as a crisis dose, 1 mg per kg per dose 6 hourly, mostly 3 to 5 days, and do get good results about hydrocortisone. That's what we use. So what I told you that, I told you the two drugs. I told you these two drugs, which is one, which is norepinephrine, and I told you this vasopressin. The norepinephrine, as you know, as alpha receptor action as a systemic vasoconstrictor. And there is alpha 2 receptor which releases your nitric oxide synthesis or nitric oxide release, leads to vasodilator. Very important action. Same thing about vasopressin, as V1 receptors are vasoconstrictor and V2 receptors are specially release of nitric and vasodilatation. So these two drugs, now one more RCT going with my unit is comparison of norepinephrine versus vasopressin in sepsis. Because these two drugs are very important. What I'm talking as when I take a class later on about sepsis, this is also very important in those ones. I told you that I don't use the dopamine because it has pulmonary, systemic as well as pulmonary vasoconstrictive effect. And I just discussed about milrinone as inodilator. I just discussed about dopamine as ventricular function. So this chart is simple chart where you can think about using this chart. What we can think about using this chart as, sorry, what I told you about the blood pressure normal, ventricular function good, sildenafil, nitric oxide. Blood pressure normal, ventricular dysfunction, you know. Blood pressure low, ventricular restriction good, noradrenaline, adrenaline, vasopressin with fluid. Low blood pressure, ventricular dysfunction, combination of milrinone plus noradrenaline. And this combination is very useful, which I need to document as observational study. Combination of noradrenaline and milrinone in late onset sepsis. Again, those are the patients where we can think. I know it's going too long, but I hope it's okay for you guys because still there is some material left. Akash, should I continue?
How many more slides, sir?
Probably again 15 more minutes.
Okay, sir, please continue.
Or that's what another case, which is the term baby, which was stable, which was with mother breastfeeding, and then deteriorated, acidosis, high lactate. You know the diagnosis. Most of you will do the echo, and that echo with the TR jet. Yes, there is a TR jet, but with the TR jet there is a parallel circulation. So this is another event of pulmonary hypertension with associated, you can see the parallel circulation, and this parallel circulation, naturally, you need to think about keeping the duct patent here, and keeping that duct patent, what we call duct dependent circulation, we require prostaglandin. And as you know about the prostaglandin here, we know the prostaglandins basically. The prostaglandin again through this pathway of cyclic AMP acts as a vasodilator. Prostaglandin keeps that duct patent, reduces your pressure overload. So that is what action of these prostaglandins, what we use in this case of pulmonary hypertension. Naturally, the dosage, as you know, but be careful about using prostaglandin because of the hypotension, systemic hypotension, apnea. These are the side effects. So the major side effects basically is hypotension and apnea. So be careful about using of this one. The fourth condition of pulmonary hypertension is a plain lung disease, severe RDS or severe pneumonia with parenchymal lung disease with left to right. What you require is lung recruitment. These are the four conditions what you compare. So these are the four conditions we saw. Naturally we saw the pulmonary hypertension with the severe TRZ and the bidirectional PDA. Nitric and sildenafil is the drug of choice. What we saw, LV dysfunction, we saw the dysfunction of the ventricle, we saw the milrinone as the drug of choice. We also saw the lung recruitment in cases of plain lung disease, and we saw the drug-dependent circulation, where prostaglandin even alprostyn drug of choice in these cases. Now, few of the alternative therapies which you should know, which are important, which are coming out in a good way. These are the PGI2, endothelin receptor, and hydrocortisone. So as you know, these prostacyclins are systemic and pulmonary vasodilatation. Again, problem with hypotension, but they act through the cyclic AMP. Just now we saw the PGE2 and PGE1 and PGI2. They are acting through the cyclic AMP, leading to vasodilatation. There are a lot of studies, but most of the importance are now coming out for chronic pulmonary hypertension, for BPD pulmonary hypertension, that they are coming out. So inhaled prostacyclins, a lot of studies are coming out. If you see the iloprost or ibuprofen, they are the one which are coming out in a big way, and in the West they are using quite a long way. What about Wasanton? Yes, probably from Indian setup, that's a good drug. That is ET1 antagonist. Again, observational studies and the future trial. That's what you saw, that they all have. You know that Wasanton actually has the ET receptor antagonism, because ET receptor has a constrictor effect that will lead to the relaxation as vasodilatation. Hence, the Wasanton, naturally PPHN not responding to oxygen or inhaled nitric oxide synthesis, mainly for chronic pulmonary hypertension. You can use 1 to 2 milligram per kg per dose, 12 hourly, but be careful about hepatotoxicity, monitor those enzymes. That is about Wasanton. And Cochrane about Wasanton, yes, we need to think about more studies, but definitely that's where we required. This is where about the preterm BPD pulmonary hypertension, but I told you I'm going to take another class on the preterm BPD pulmonary hypertension. We'll update you guys about the session about that one, about preterm BPD pulmonary hypertension. But what is there is sildenafil, milrinone, Wasanton, that is the Flolon, iloprost, and terrified. But unfortunately, these drugs are not freely, but these are available for us. Mainly these are available for us, and that is what we use in cases of Indian scenario. Steroids, as you all know, just I told you, the last discussion comes out as steroid. That is what we all talk. Myself, I will not go, but this is the chart, probably what you need to understand, what we just discussed. Stabilization with inhaled nitric oxide, sildenafil with blood pressure stabilization, fluid vasopressin steroids, myocardial dysfunction with milrinone, Wasanton as a third line. This is what Professor Martin Tocco is writing, as you know, the neonatology questions, series of the questions. That series, 6 books by this one, and the one book is on the neonatal cardiology. Now the book name this year will be neonatal hemodynamics, and that hemodynamics, Professor Martin has requested our team to write on hemodynamics in the developing countries, and this is the chart we have proposed for the pulmonary hypertension management in developing countries, especially when we lack those ones. So that is what at present moment our thought process about these ones. I will not go in detail. There is a separate class on the emerging drugs and animal experiments. It's a huge class for DM candidate. I know you might be thinking I could have taken this one as a separate class, or you wanted to listen this one, but again, it's a big session. So I think I will not go into that detail. I do understand you all will be interested in this class. One day we'll take this class also. So dear friends, I know there is a lot of time shoot out from my side, but there were a lot of points I have to cover. I told you there are 10 questions: transitional circulation, pathophysiology, echocardiography, management part 1, management part 2 as inotrope, management part 3 as separate nitric or sildenafil, or what you can consider as the additional vasodilator therapy. Those are the things. But what we learn, lung recruitment is very important. High frequency early use of surfactant, early use of nitric, backbone of PPHN. Nitric is selective vasodilator. Milrinone